Good afternoon again, everyone. Uh, the next session is on palliative care beyond borders. For this session, we have Dr. Seema Rao as the chair. Dr. Seema is an experienced psychiatrist and palliative medicine specialist from the Manipal Academy with a keen interest in geriatrics and palliative care. She is skilled in psychotherapy and end-of-life issues such as dignity therapy, spiritual care, research, mental health counseling, and pain management. I now invite Dr. Seema to take the stage.
A very good evening to all of you. I think the coffee and the tea must have made you fresh now. Like palliative care is always at the fag end of every workshop. Okay, so I should thank the organizers for giving me this opportunity to talk about palliative care, interestingly, beyond the borders. Okay, beyond borders. Palliative care has been in existence for almost more than 3 decades or so, but has been confined to cancer care and to the terminal phase of life, towards end of life. Now, I'm happy to say in the past decades or so, these borders have become more porous, it has been broken down, and palliative care is now being provided for various chronic life-limiting conditions and more or less starts right from the time of diagnosis and runs along with curative care. It is an approach actually that looks at, since morning we have been hearing about the suffering of an individual being more than just physical, right? So palliative care is something that focuses on the physical suffering, on the psychological part of it, the social aspects, as well as when patients near their end of life on the spiritual and existential aspects also. Despite this, sadly, though it is a major part of care provision, almost 80% of people who require palliative care do not receive it. So if you are talking about universal health care, now we know the 4 pillars, right, of prevention, promotion, treatment, and rehabilitation. The 5th pillar becomes palliative care. With this background, and especially in places where there are humanitarian crises, like whether it is war-torn countries, the provision of palliative care is almost nil when the need is extremely high. So with this background, I would like to invite the first speaker, Rachel Nyanzi. She is a pediatric critical care nurse at McMaster Children's Hospital, as well as a research coordinator with the Humanitarian Health Ethics Research Group at McMaster's University in Hamilton, Canada. I just invite her for a speak.
All right, can everyone hear me okay? Thank you so much for being here, and I also want to just particularly thank all of the staff at MSF India for facilitating my being able to attend here. So I'm going to be talking today about a qualitative study that we did with refugees and healthcare providers working in Jordan, Rwanda, and Bangladesh. The work I'm going to be discussing today is part of a larger study called Aid When There Is Nothing Left to Offer, a study of ethics and palliative care in international humanitarian action. The study is led by the Humanitarian Health Ethics Research Group, which is based at McMaster and McGill universities in Canada. Though I've worked with MSF in the past, the current research is not sort of specifically with MSF. It's with a variety of aid organizations, but we do collaborate quite a bit with MSF in our research. The study was funded by ELRA's R2HC program, and I'll be describing some of those results today. So even though humanitarian aid focuses on alleviating suffering and promoting dignity in the recipients that we interact with, aid actions do still tend to be rescue focused. The unfortunate reality is in a lot of the settings where we work, a lot of patients are going to die, regardless of what we do. This might be because they were already living with a life-limiting illness, or because of the event itself. And so the question becomes, what is it that humanitarian aid organizations can and should do for these patients? This slide gives a little bit of an overview of the larger study that we've done over the last few years. It began with a literature review and sort of mixed methods survey, and then focused primarily on semi-structured interviews. I'm going to focus today mostly on the in-depth case studies that were conducted in Rwanda, Jordan, and Bangladesh. Initially, we had planned to do just 2 case studies in Jordan and Rwanda. However, during the course of the study, the Rohingya crisis developed in Bangladesh, and due to some connections we had, we were able to do interviews with a palliative care physician and 2 lay health workers working in Cox's Bazar. We didn't unfortunately have the opportunity to interview refugees themselves in that context, but we still feel that it was a really valuable experience. The case studies were selected in order to provide a bit of diversity of sort of the length of the refugee crisis, from a more acute crisis in Jordan, although it's now been going on for years, versus the very protracted conflict in Rwanda, where some of the refugee camps have been there for more than 20 years. The study was done using a qualitative constructivist approach, and interpretive description was the design that we used. We conducted semi-structured open-ended interviews and did data analysis using in vivo 11 software. I won't get into the methods more than that, but if anyone has questions, I'm happy to explain a bit more at the end. The 2 graphs on the slide here show a bit of explanation of the types of diagnoses that the refugees themselves were living with. We interviewed both refugees living with terminal illness as well as serious incurable chronic illness, things like renal disease, cancer, lung fibrosis, as well as blast injuries that were chronic. So I want to discuss mostly the themes that emerged, because that's probably the most interesting part. There were a few themes that were quite specific to some of the case studies, and there were others that sort of were overarching across the whole study. The first theme that was very specific to Rwanda was the issue of social death and stigma, as we've been discussing quite a bit today. In the quote at the top of the slide, you hear from a young man who is 24 years old, living in a camp in Rwanda. He's the sole care provider for his younger siblings, and he has leukemia. He spoke about how when he would go to seek care in the community, his neighbors would come and steal his things from his house because he was assumed to be essentially already dead, the way he was treated. There were a lot of people who also spoke about concerns about their children and their family members and what would happen to them after they died. That was a very pressing concern expressed by a lot of the participants. In Jordan, there was an interesting dynamic whereby the refugees themselves were from Syria, where prior to the war they had had access to a very high level of health care. And so there was quite a bit of frustration where they were making comparisons between the care they used to receive in Syria versus what they had access to now in Jordan. There was also a very difficult socio-political context where there was sort of rising tensions between the local Jordanian population and the Syrian refugee population. And there was actually a recent change in the policy around access to universal health care for the refugees. And because of this tension, we were asked to interview about 5 or 6 Jordanian nationals who were also living with a life-limiting illness in order to sort of alleviate the perception of favoritism towards the refugees. We found this actually to be an extremely beneficial practice, and we were able to look at sort of the differences between those 2 communities. In Bangladesh, even though we were interviewing people who were working in a specifically focused palliative care program, there was a lot of blurring between what is palliative care and what is curative care. They were actually providing care to essentially anyone who was sort of falling through the cracks of the humanitarian health sector in Cox's Bazar. A lot of people who were discharged from facilities and referred to them for care where the aid organizations just didn't know what to do for these patients. And finally, the staff there also reported a lot of personal satisfaction and pride in the work they were doing in Cox's Bazar. Excuse me, I'm just getting over a cold. I now want to talk about some of the overarching themes from the study. This gives just an overview of the themes that emerged. The first theme was labyrinthine care pathways and long waits. So refugees in this study described being required to go for verifications, to get letters of support, and a lot of different bureaucratic delays that got in the way of them accessing care. In the first quote, this is an interview that was done through a translator. So the translator was explaining that this woman had discovered a lump in her breast, and it wasn't until about over a year later that she actually had a final diagnosis of cancer. And in that time, her tumor had grown in size significantly. So there's a lot of stories of people who these bureaucratic delays were actually what contributed to the fact that their illness had become terminal at that point. There were also a lot of refugee participants who had stories similar to the second quote on the slide that says, "They stopped providing me with food coupons because I couldn't go for required verifications." So this woman spoke about how the fact that her palliative diagnosis, or her diagnosis itself, was actually getting in the way of her being able to access services and care that she needed. The next theme is inadequate access to symptom control. Now, I'm sure if people that work within MSF or in other agencies are probably not surprised by this, but over and over again we heard stories of people having inadequate access to symptom relief, including pain control, but as well as things like relief of nausea, relief of constipation, difficulty breathing, and things like that. I want to read a quote from a local physician that we interviewed. She said, "Actually, for palliative patients, they're doing nothing. I should not say that, but they're doing very little. They can't even provide pain management. You know, an organization like that, they don't have morphine or morphine tablets. This is frustrating, isn't it? At least they can give pain management to the patients who are having moderate to severe pain. So it should not happen. They do not have any morphine. They are referring patients to my organization, which is, I think, the smallest organization in the camps. An organization that is working all over the world. Why should that be?" She goes on to explain one of the really important and difficult consequences of this situation, where patients go to seek care in a clinic for severe pain, and they're given medication like paracetamol or acetaminophen that really does nothing to relieve their pain, and so they feel there's no point in seeking care at all. And then a lot of aid organizations have the perception that there aren't any palliative care patients in this camp or in this setting. So there's an issue with invisibility of patients with palliative care needs. But that could be a consequence of our practices. The next theme was related to silence around death and dying. I'm not going to read both of these quotes, but if you can read them while I'm speaking, I think it would be worthwhile. In all three of the case studies where we worked, it was culturally very inappropriate to speak openly about death and dying with patients and with their family members. A lot of the healthcare providers felt that you want to provide psychosocial support, you want to be encouraging to the patients, and that was not seen as compatible with talking honestly about death. This was very difficult for some of the people we interviewed who come from cultures where we speak quite directly about death. For them, it was often people spoke about how, can you really provide palliative care if you're not talking honestly about death? And so there was this tension between those 2 points of view. And then the last theme I wanted to talk about, the second to last theme I'm going to talk about is the false dichotomy. So a lot of healthcare providers working in humanitarian aid really struggled with the belief that if you focus energy, resources, and time on palliative care, that necessarily detracts from your ability to invest in interventions that save lives. They were seen as mutually exclusive. And there were also healthcare providers who did challenge that notion that they're mutually exclusive. This was in direct contrast to many of the patients who spoke about the small interventions that would have made their quality of life much better and improved their ability to cope. As one refugee in Jordan said, if someone could just bring water to my tent. There were a lot of beautiful examples of people asking for things as simple as a light so that they could find their way to the bathroom at night, or a fan to help cool them, or even just someone to hold their hand and be with them. Some of the healthcare providers also spoke about examples of providing palliative care, even if they may not have really conceptualized it as palliative care. As this person said, holding the hand of someone who's dying and letting that one go peacefully. But to that person, that will be what he leaves this world with, someone who cares. The results of this study really point to the need for palliative care strategies, things like pain management, symptom management, psychosocial support, integrating family into your interventions, to be integrated into the care for all patients across the continuum of care. There's a number of factors or contexts that are unique to humanitarian aid, or maybe in other settings, but are very severe in humanitarian aid settings, including the fact that we aren't always sure what the patient's actual diagnosis is and what their prognosis is. We can't always define that very clearly, and so for people to say this person's clearly at end of life isn't always clear. Also, this issue of silence around death and dying. We don't always have time to try to increase awareness of the need to talk openly in a context where we're only there for a couple of months or even a few years. Also, fears around opioids and the conflation between euthanasia and palliative care make things difficult. And so we would suggest that it's important to integrate these strategies even alongside curative care if needed. So I just wanted to mention that if in cases where we feel like there's nothing left to offer, I would encourage people to think about what can we do for this patient. As one person really beautifully described, we can help them to land softly. That's the goal of palliative care. Even if we can't cure them, we can still relieve their pain. We can still make sure they're not alone. And I want to spend a couple of minutes just discussing a couple of very practical examples that some of our participants gave us. We interviewed people that had a wealth of experience, and I want to share some of these ideas with you. One of them had to do with especially during emergency responses where people feel that they don't know enough about the cultural context to provide culturally appropriate palliative care. The role of the psychosocial worker, I think MSF, as far as I understand, is quite good now at making sure that there are psychosocial workers in most projects. And that person can have a really valuable role in assessing the local practices around death and dying and making sure that that's communicated to the rest of the team. Our partners in Bangladesh have made really interesting use of technology, including WhatsApp, to allow a palliative care expert to supervise lay health workers working in a camp that's remote from her. And then in terms of facilitating community supports, we worked with I interviewed someone who had responded to flooding in Pakistan a few years ago. And they came upon a woman who had lost 2 children under the age of 3 the day before. And the woman was distraught, and unfortunately it was a mobile health unit, and so they were only in the community for a couple of hours. But they were able to set up a system where they worked with women in the neighborhood, and and they were able to have women come and visit her at least twice a day to make sure she was okay. And finally, the idea of making sure that during a mass casualty event, you have a tent that's reserved to create a bubble as best you can for patients who are dying and their grieving families. I just want to thank the participants, especially those living with a serious illness, for sharing their thoughts. Thank you again to R2HC for their support, and to MSF for allowing me to come, and the rest of the research team. And if you're interested in hearing more, this is our website. Thank you.
Thank you, Rachel. That was a very nice presentation. Now I would like to call upon the next speaker, Dr. Fahim Omar, to come on stage. Dr. Fahim is a pediatrician from Kabul, Afghanistan, and he works in the Department of Pediatrics and provides palliative care to the neonates and infants there. So I would invite Dr. Fahim Omar on stage.
Good afternoon. My English is not very good. Please forgive me if somewhere my English is finished. In one night shift, when I was in duty, there was born a baby with marked congenital anomaly. It was a neural tube defect. And at that time, I didn't know what should do with this baby. I knew that kind of cases, it's difficult to manage, but I didn't know what should I do. On that time, I called one international pediatrician from Canada and asked him, what should I do with this case? He told me, admitted this baby at your newborn unit as a palliative care. On that time, what's palliative care? After 7 years of my experience in pediatrics, I didn't know what's the palliative care. And today I'm here to just share our experience in Kabul, Dashtiberchi project. Dashtiberchi project, it's a maternity project that's supported by MSF, just the maternity side. It's a very extremely busy maternity. It's about 1,500 delivery per month. We have a newborn unit which had 50 beds. In this case, we are very busy. Sometimes you're overcrowded. And in 2018, the mortality rate was 4.8 because we are in the intermediate level care, and we have very limited referral options, especially for tertiary hospital. In 2018, we discharged about 25 babies with palliative care to whom. But the babies that stay in our newborn unit and died after that, that numbers we don't know exactly because the data collection is some things. Yeah. What's our definition from palliative care? I think there is many definition in different literature, but the definition from the MSF guidelines, when the therapeutic therapy is not in the baby's best interest, but still we can do something, like to comfort the babies. The aims of palliative care to treat the pain or another symptoms, but we are not working or we are not doing to delay or hasten the death. When we started palliative care on 2014, there was many barriers. There was 3 main barriers. The first, it was very new in our country, as I said in my story, because all the times in public hospitals and other hospitals, we're just trying to cure the patient. Sometimes it's difficult to treat something, but just we are trying to treat the patient. There is any guidelines from the MUPH side that we can follow that. The second issue is the legal issue. There is any clearance in our health policy. In this case, the physicians that they know about the palliative care, they think it's illegal. Maybe if they implement it, they face with some problem. And the third big barrier was about the culture and religious. The main religion in Afghanistan is Islam, and the people respect it very much to that. And according to this religion, we should cure the patient, not let them to die. It's also difficult for the staff and difficult for the caretaker because they think if they go with the palliative care, maybe it to be a sign. In this case, it's very difficult. Finally, after many challenges and barriers, we started palliative care on 2016. The steps that we followed with palliative care, the first step, it was about the, making decision on the babies or the patient that is candidate for the palliative care, how we can make a decision. We started with do not resuscitation or DNR, especially for the babies which suffer from long time resuscitation or the babies suffer many time resuscitation. We just goes with do not resuscitate it. And the second stage, we involve the parents when we are making decision, like a dialogue. Within the team, when we, all the times it's not very easy to make decision for the patient that should go. For some things like to congenital anomaly, the mark one, it's maybe it's easy, but for some cases it's very difficult because in MSF setups, sometimes we don't have many facility to have an exact diagnosis, and it's very difficult. In this case, we have a team from the pediatrician supervisor, and nurse supervisor, and sometimes we need the international staff because in country like Afghanistan, the people don't believe their own physician. When they face with someone from the foreigner, especially with the light skin, they believe too much. And then we work to communication with the team, because at the first, when we make a decision, like after recitation, a baby, the pediatrician decided after 20 minutes we will stop the backmouth ventilation and then khalas. But midwife on the delivery room, he didn't know about the palliative care. He came to us, why you stop? Baby still has some heartbeat. Why you stopped? And she complained, and it make a big challenge for us. We need to improve this one, and sometimes it's needed to communicate with the caretaker. When we made the decision and the parents agreed to palliative care, when we started palliative care, we have a framework. After the decision, we try to stop all the curative treatment. It's not very easy because some people are very sensitive, especially with the stop to oxygen or stop to IV fluid. They think, no, stop everything, but just not stop the oxygen because you will kill my babies. And also we have a policy for the treatment of the pain, for the convulsion, and also for mouth, eye care, and keep warm. If some babies can drink, we can feed the babies. And also for the parents, we have a psychosocial counselor 7 days per week. The second challenge we faced, it was about communication with the parents. It has because of 2 factors. The first factor because of the to have a counseling with the parents, it's not like to learn somewhere, to read some books. It's very difficult. And all the pediatricians are not the same. Sometimes the pediatrician talk with the parents in a public and make problem. And the second problem, challenge was with the parents. As I mentioned before, it's very difficult for the parents too, especially if there is a baby boy. It's very important for them. Or sometimes the family has a baby from a long time, like 10 years, and they came to India for some treatment. After that, when they deliver and face like this condition, they just, no, you should cure my patient. And it's a big challenge for us. Okay. We are during the counseling with the parents, we talking about the diagnosis, about the possibility of the referral, possibility of the treatment. We are talking about short-term outcome and long-term outcome. Yeah. How we improve the implementation of palliative care in our project. At first, we collected feedback from our pediatrician, from our colleagues, and sometimes we need to support them because the pediatricians thought if they implemented palliative care, they may be because they think it may be illegal. But recently, there is a cancer center, it's from Minister of Public Health, and they're trying to implement palliative care. And then we have a palliative care committee. This committee had two tasks. The first, about making decision for some difficult cases, and the second task is about counseling with the parents. But we still need to improve somewhere because sometimes the non-medical staff also need aware about the palliative care, like the cleaners, the guards, because we face with some problem. When we make decision, that medical team make decision about the palliative care, some of the cleaner camps, oh, this baby's breathing. Why this baby is not in the newborn unit? It's just ask the doctors. It makes some problem, and we need to aware this. And also we need to make a link with the cancer center. It's for adults, but at least Minister of Public Health started about the palliative care. After 3 years of practice with the palliative care, we have still have some challenge. Still, the pediatrician not feeling well. I think that it's very difficult for a physician, for a doctor. They think they just fail because we think we should cure the patient. When we are thinking about the palliative care, it's difficult for a doctor to make decision. Because it's stressful. Like I'm the pediatrician supervisor there. In the midnight, some 2 a.m., 3 a.m., they're calling for me. The pediatrician, they're on the duty. They're calling. We have a patient. We recitated, but they know what should they do. But they just because to pass some responsibility to another to decrease their pressure, they just called me and. I said, you just go with the palliative care, and tomorrow if someone asking, they just sign me. He told me. Yeah, now there is a case. It was about 3 months ago. There was a term baby with normal birth weight, that baby born by vacuum. Baby suffer from birth asphyxia. Baby received backmouth ventilation for more than 9 minutes and then started some breathing. But when we transferred that baby to our newborn unit, baby developed recurrent seizures, and we try all the drugs for antiepileptic drug from first line to third line. Finally, we could control the seizure, but baby not developed. And after 1 week, the baby was flaccid, baby was in coma state. We started counseling with the parents, but the parents said no. After 9 years, I have this child. Anyway, you should treat this baby. Maybe in this, after 21 days, the parents accept, but during this duration, maybe we talk more than 10 times. We had more than 10 times counseling with the parents. Finally, they accept, and this baby just got some small amount of milk by cup spoon, and we discharge this baby to home with palliation. Yeah. In the conclusion, it's possible to implement a palliative care, but we should be strong, especially with the counseling with the parents, and also communication with the team. It's very important. And role of the palliative committees also, it's good. At the end, thank you.
Excellent presentation, Dr. Fahim Omar, and very inspirational, the story. Very extremely inspirational. What you forgot is it is extremely important to have a champion like you along with that, who respects accepts palliative care as a continuation of provision of care. Yeah, thank you. So I think the floor is open for questions, if anybody has. Yeah. Any questions?
Yes, thank you. This is a question for Dr. Fahim. I think one thing you talked about in your presentation towards the end sounds like a sort of community of practice, because you started to talk about the cancer center, and I just wondered, do you see the possibilities for sharing experiences between the MSF hospital and the cancer center, or sharing expertise or staff going between these centers? And I'm just thinking more broadly, by sharing the experiences between our MSF structures and Ministry of Health structures and other MSF structures in the region, could that be a good way to contribute to addressing these barriers, which are different in each place, but still some similarities? Thank you.
Yes, to make a link with this center, we just, because we know still the people they are working there, they are not very sure about the palliative care by themselves. And they're now starting to work on palliative care. It's a good news for us, just to doctors don't feel it's illegal. It's an important point that when the Ministry of Public Health start this program, at least it's for us that's not illegal. After that, our physician, our pediatrician, they don't scare from if someone asking why you implemented palliative care. In last month, we had some visit there, but still they are in a very basic state. They don't have made any policy, but just they're trying to start the palliative care.
So I'm very curious to know, actually, from Fahim, at which point your therapeutic care stops and moves on to palliative care? It's a curious question for me, because it's so new in the country and you're just about starting palliative care. At which point does this transition happen?
I think it was very difficult because at first we should start from our staff. Because when our staff, the pediatrician, our nurses, when they don't know, our midwife, we started to aware or to inform them. We, for
2 years, we just train our staff. And we explain them what's the palliative care. Because in the past, we think, including me, it's maybe a sin from the religious side, and from the legal side, it's illegal. But when we explain the palliative care, like for a patient, like example, like have a congenital heart disease, and there is any center that could do something, what should we do? Should we go with the antibiotic, or should we go with the IV fluid? Which treatment do you give for this baby or for this patient? And that time we knew that we needed some other ways. That's the palliative care. Yes, can't cure or treat this problem, but at least we can comfort the patient. The first step was about to inform our staff, and then from the legal side, on that time it was not sure. We talked with our coordination. The coordination, I think, in the desk from legal side of MSF, and they said we have the email with the Ministry of Public Health, and they accept everything, and we support you. And from the cultural, still we face with the problem, because if we talk with the elder or we call the mullah, because if we talk with them, they don't accept. In this case, we are not in the community. We just talk with the parents, not the elders, because some of them illiterated. If we talk about the palliative, they don't catch us. Yeah.
Just to add a point to your question, actually, it is not mutually exclusive. Curative intent care and palliative care can go on side by side. The palliative looking on to symptom control, psychosocial aspects, the aspects of suffering, curative treating the disease. So at some point, when you reach a point where you feel, as a physician, this is not happening, and then the transition, sort of, the palliative care takes over at that point in time when you realize. And there are specific guidelines for different disease states that is there, where at that point you need to involve the palliative care. There are specific guidelines available.
Hi, thank you for the presentation and wonderful sharing of your experience. My question is for Dr. Omar. Omar, if you, in your setting, if you had access to some expensive treatment and diagnostic modalities, would that change your treatment approach when you take the decision for palliative care? That's my first question. And the second question is, you talked about your team taking the decision for palliative care. Do you think having caretakers or parents in the team would be beneficial or not? Just a question.
Because sometimes we are not sure about the diagnosis. Last month, we had a patient that's after 20 days still suffer from hypoglycemia. And we didn't know what's the cause of this. If we had some facilities that can diagnose what's the exact diagnosis for this patient, after that it's easy for us to make a decision. Is it treatable inside of our country? It's treatable to refer to any tertiary hospital, or maybe if the parents able to go to some country like Pakistan and India. If we don't know and just going with the dark, it's very difficult. Just for clinically, it's very difficult to know what's going on, and this is make difficult the decision. The second part, yes, when we starting talking with the team about what should we go with the palliative care, we invite the caretaker, especially the mother. When the mother is present, we just talking or medically, but we are trying to use non-medical words that the parents know what we are talking about. Yeah.
Thank you.
I think we can just take one question. 1 minute is left. So.
I'm very touched with your, amazing story you have shared with us.
I have one question. I don't know whether it can be relevant or no, but it's just stuck in my mind. That sometimes, as you know, that curative treatment can go along with palliative, or sometimes maybe the curative treatment can really do well. But my question is just striking my mind is, are people in Afghanistan with health insurance, government health insurance, like especially with children? Or
No. We don't know what's insurance. Yeah, sometimes it's some cases we at the first we are going we think maybe this baby is not improved. We decided to palliative care, but we keep on the palliative care, like especially for birth asphyxiated baby. Neurologically, it's the literature says that when the baby is in the SARNA 2, 3, it has a poor prognosis like this, but we face with some cases, especially with SARNA 2, after 2 weeks, still baby is not very good. But when we started palliative care, after some times, especially after 3 weeks, the baby's improved, and the parents sometimes came to us. You said this baby is not, but yeah, we change. It's sometimes it's needed to from palliative care we go to curative therapy.
I think the time is up now, but rest of the questions we can take personally during before we leave. I think it's been a very good presentation. Both Rachel and Fahim have given us a concept of palliative care among the vulnerable people in whom even primary health care is difficult to reach. So it is possible to provide palliative care, and I think this is something, this concept we need to keep in mind and train ourselves on how to provide care. Thank you.